So good evening, friends. I'm Dr. Vijay Agarwal. I'm the president of Consortium of Accredited Healthcare Organizations, CAHO. So on behalf of CAHO and on behalf of Dr. Dhruva Chaudhary of the Indian Society of Critical Care Medicine, and on behalf of Walter Kluwer, who are the makers of Up to Date, I welcome you all to the second episode of our webinar, which is directed towards understanding the management of COVID positive patients, and especially trying to take a global perspective and having an interaction with our international experts. So we are extremely pleased to have today with us Professor Rahul Khosla, who is the Chief of the Pulmonary and Critical Care Medicine at the Veteran Affairs Medical Center and Associate Professor of Medicine at the George Washington University, Washington, DC. We also have Dr. Rahul Sarkar from the Medway NHS Trust of United Kingdom. And we are likely to join very soon by Dr. Ramanathan, KR, from the National University Hospital of Singapore, and Dr. Jennifer Mitty, who is a clinical associate professor of medicine at the Warren Alpert Medical School of Brown University and an infectious disease specialist. And she's also a part of the editorial team of Up to Date. And we have two very illustrious persons to take this discussion forward, along with our lot of very distinguished intensivists from all over the country. So I'll hand it over to Dr. J.V. Peter, who needs no introduction. He's the chief of the intensive care and head and chairman of the CMC Vellore, and Dr. Sumit Ray, who is the head of the intensive care medicine at the Artemis Hospital, Gurgaon, New Delhi. So over to you, Dr. J.V. Peter.
Thank you so much for those introductory comments. Sumit and I are very privileged to be able to be part of this webinar, and thank you for giving us the opportunity to chair this session. We are extremely privileged to have international faculty, experts of experience in managing COVID patients to share their thoughts with us. We are also extremely happy to have our Indian counterparts who have been managing COVID patients, and I'm sure the discussions are going to be an academic feast. To chair and co-chair and coordinate such meetings on an online platform is not easy, but we will try and do our best. We thought in order to utilize the time effectively, we would put down some questions and thoughts. We are not restricted to just these questions, but I thought it will get the ball rolling for our discussions. So we'll try and keep it as focused as possible. And it is not, again, restricted to the individual people whose names I mentioned there. Others can also contribute. And so maybe we can start with, I don't think Dr. Jennifer has come, so we'll start with the second question first. There is a lot of concern on the use of non-invasive respiratory support or non-invasive ventilation in COVID patients because of the potential for aerosol generation. The question is there any role at all? If so, what is the subset of patients on whom you would try? How long would you try? Is there any evidence of efficacy in these patients? I have actually put down Dr. Rahul there to open the comments on this, and we can take it from there.
Thanks, Dr. Peter. This is a very topical question generally across the globe, and the guidance about this has varied in the last couple of months as we are learning more about the disease. To start with, I should just say that I think we are all here to share our experience rather than giving generally any advice to anybody, because we are still learning, all of us. Now, with CPAP, at least in UK, there were two different thought processes initially. Aerosol generation was a huge concern, and for that, lots of hospitals decided not to use CPAP at all, and including high flow nasal oxygen. And on the other hand, some other hospitals, which includes us in our center, we decided to just go with the usual practice of using high flow nasal oxygen and CPAP both as we saw fit in a group of people. And therefore, we have actually used CPAP in lots of patients. And what we have seen is that in the people who are for full escalation and all sorts of full escalation to invasive mechanical ventilation, in that group, up to around 40% of the patients did manage to be discharged home following just CPAP therapy. On the other hand, if we decided that we would not give them CPAP, then they would certainly end up being intubated. And we know that intubation has a fairly poor outcome in this patient group. In the ICNAC data across UK, we have seen that around 65 to 70% people died when they have been ventilated. So in my view, and I'm very happy to be corrected, is that if we feel that a group of people are suitable for CPAP therapy, I would have no qualms about using it. But we should remember about the safety of healthcare professionals as well. Now, if you look at the literature, there is no appropriate literature about aerosol generating capacity of CPAP at all, other than 1 or 2 papers. And in the papers that are available, that only mentions aerosol dispersion only to a very limited distance around the patient. And to rectify that situation, we actually did a project in our hospital trying to measure CPAP around the patient with, trying to measure aerosol around the patient with CPAP and high flow nasal oxygen. We did a collaborative project with King's College, and we are writing the report now. It's a bit ambiguous from what we have found, but generally speaking, there is no difference, at least between high flow nasal oxygen and CPAP therapy. And as I mentioned, that it has helped us to get around 40% people who are for full escalation out of the hospital without having to escalate them to invasive mechanical ventilation.
Taking from there, if I can ask you a very leading question, how long would you try them on non-invasive respiratory support before you decide that we need to intubate? Because the natural course of the illness is that it's quite long compared to the COPD exacerbations or cardiogenic pulmonary edema, where it's reasonably short. So what is the threshold you've been employing in your cohort of patients?
So for the patients, and I just mentioned CPAP here to start with, for the patients who are on CPAP, what we did was we had a twice daily assessment of those patients by the intensive care consultant, and just so that one person can assess their clinical status. In my experience, what I have seen is if the patients have very high tidal volume on whatever pressure they're on, or low tidal volume, we found that is bad. On the other hand, if the tidal volume was in the region of around 8 mL per kilo or thereabouts, they did well. But we found that very high tidal volume was associated with increased work of breathing, and they were more susceptible to fail. And then there is another small group of patients who are very obese, and those patients will obviously have a second pathology, that they might have an underlying obesity hypoventilation, and those patients obviously will struggle on just CPAP. So we then put them on some NIV as well, non-invasive, with a fairly high pressure. And the CPAP pressure, the P varied between around 10 to 15 in these patients. Some guidelines have mentioned that try CPAP only for 2 or 3 hours, but we haven't done that. Generally speaking, the twice daily assessment worked well. We identified patients quite early on that these patients will not go well. The clinical features that we went with was obviously accessory muscle use or thoracoabdominal dysynchrony or very high respiratory rate. By high, I mean more than 40. We have found quite a few patients who have been between 35 and 40 of respiratory rate for 3-4 days before being de-escalated. So my take from this is that we should look at the effort of the patient, and we should, the way we did it is we assess them individually rather than having a blanket protocol for all of them. And that needed a very individualized assessment for these patients in a subtle way.
I'm not sure if I'm missing something. Why CPAP and not non-invasive respiratory support, non-invasive ventilation? Why not an inspiratory support? Logically, you would think that they will have ventilatory fatigue. They need more inspiratory pressure support. So why CPAP?
As I said, so far we have seen that CPAP has been helpful. On the other hand, when we are starting, at least from previous evidence, we had some signal that NIV could be harmful in ARDS patients. And because there are few hypotheses about that NIV can generate too higher tidal volume in some people with high effort, or that is the main hypothesis really. So that's why we stayed away from NIV for most of them, unless they had an underlying COPD or wheeze or any other bronchial obstruction, or they had fairly raised BMI. For everyone else, we just use CPAP, and that has worked in some people. Up to, as I say, 40%.
Thank you. Would other international faculty like to comment that they have used non-invasive ventilation for their patients?
So this is Rahul from Washington, D.C. Good morning, good afternoon, and good evening to everybody. We are in different parts of the world. So our experience, I think, as Dr. Sarkar was saying, alluding earlier, was there was concern for generation of aerosol with the use of non-invasive ventilation. Although, as he mentioned, we didn't have any literature to support or dispute the fact. Although there are certain facts that are coming out. I've read some papers, especially about high flow nasal oxygen and some about CPAP, that there may be some aerosolization. But as he mentioned again, that the particulate matter doesn't go too far from the patient. And secondly, it stays in the air for a while, for a few hours. That is a concern. The concern initially, in our experience, was when there was a shortage of PPE. But if you have adequate PPE for your healthcare personnel, so it's a very unique phenomenon that we are facing. We are facing patients, if they didn't have this, virus, we would be managing this patient with non-invasive ventilation or CPAP to begin with, if they were good candidates. But we have this unique situation where we have to protect our healthcare providers. So for this reason, we initially have not started using non-invasive. We went on to high flow oxygenation for two reasons. Number one is that, as again Dr. Sarkar mentioned, that these patients, once they get intubated, they don't do well. And we are seeing in our series too, about 80% of the patients who get intubated, they die. So from my initial experience of intubating them early and seeing them die, we moved on to not intubating them early and managing them in high flow. We have not used non-invasive or CPAP as yet. Again, the concern for aerosol generation still exists, and then there is clinical management and there is administration. The second thing is ventilators. So states, cities, hospitals which have a short supply of ventilators may have jumped onto CPAP non-invasive earlier than those who have adequate ventilators, at least in the beginning of the pandemic. We had enough ventilators to manage our patients with, but we are debating whether we should go on to non-invasive or not. Most of our management, non-invasive, has been with nasal cannulas or high flow nasal oxygenation.
If I may add one thing about the aerosol situation, is there are two things that happened. One is that we restricted the CPAP use in areas where there were PPE available. So people were going there with full PPE, not in the other areas. And secondly, the circuit was modified for these CPAP patients. So they had the mask without the exhalation port, and then following the mask, there was a filter. So that would obviously minimize the contamination of the air as well.
As Dr. Sarkar was mentioning, the non-invasive, they tend to have a single inhalation port. So one modification could be putting a viral bacterial filter in the exhalation port. So that way you can protect if you don't have a negative pressure room or adequate PPE, if you're managing these patients with so we did that with our transport ventilators or modified circuits. If we had to use we had a surge and we didn't have enough ventilators, we put a viral bacterial filter and we did a simulation that it worked.
Dr. Peter Ram here from Singapore. Good evening, everyone. I would think, there are two ways to look at this. One, you look at evidence, and two, you look at practice. If you look at evidence, for your NIV and your high flow nasal prongs. Most of the guidelines would advocate using them under safe conditions. So if you have a negative pressure room, as long as you have adequate PPE, up to a certain extent, WHO guidelines, ANZIC's guidelines, whatever you look at, or even ACCM, nobody has raised big concerns against high flow nasal prongs or NIV in a big way. Now that's on one side. And coming to the practicality, at least in Singapore, we chose not to use high flow nasal prongs or NIV, despite the fact, early in the course of the disease, despite the fact that we had negative pressure rooms, we didn't have shortage of PPE. And the only aftermath I could probably compare at this point of time is the amount of healthcare worker infection, but that's probably not related to NIV or HFNC altogether. But what we found was we figured out that people who need oxygen with just nasal prongs in the ward, if they get proned awake, they don't, their admission to ICU is very much lessened. And that clearly, helped us reduce our ICU surge during the recent surge. So what happened in Singapore was initially we managed to flatten the curve with all the precautions, but eventually we had a blind spot which turned out to be a hot spot. So all of a sudden in the last 1 week, we are seeing about 12,000, 13,000 odd patients in the last 10 days or so. And essentially what we've been doing differently, as I said, is we are proning them awake in the ward that they don't come to the ICU. People who come to the ICU, we have now slowly started changing. We give them high flow nasal prongs. We do give them in some of the centers here before they get intubated. Our experience with intubated patients has not been that bad. Of the 18, 19,000 patients we've had, our mortality is about 18 or 19. So this is the total number of deaths I'm talking about. There were about a couple of hundreds of patients who were intubated in this process, who were, went through the process of invasive ventilation and got better and eventually left the ICU. So I wouldn't know why the difference, but definitely we've been late to take on both high flow nasal oxygen as well as NIV. NIV is still not being practiced anywhere in Singapore, but high flow nasal oxygen, we've slowly started embracing it, especially in the context of negative pressure rooms and adequate precautions. Again, we have a similar experience as what Rahul was alluding to. We find that a lot of these patients don't eventually need intubation at all. And probably that's something which we learned through the pandemic.
I think the consensus seems to be quite clear that there is a lot of consensus there's a lot of concern on the use of non-invasive respiratory support in this setting. If at all you want to be bold enough to try, adequate personal protective equipment, preferably negative pressure rooms, and in the select subset of patients that Dr. Rahul has talked about, maybe CPAP, where success may be J-shaped curve, where the extremes of volumes may be detrimental. I'll ask Sumit to take on with the first question.
So anyway, so I'll ask Dr. Jennifer if she's on, or Dr. Ramanathan too. This question is directed. So the question that Peter had basically put up is that what is the mechanism of the cytokine storm, and what are the prognostic biochemical markers for COVID-19 for this storm, and is there a role for steroids in their immunosuppressant, immunomodulatory roles, or other drugs if there is the cytokine surge that we are talking about?
The answer to your question, essentially, as much as we know about this disease, we know that there is a phase of viremia, which is accompanied by a phase of host response. Most of these patients are asymptomatic during the phase of viremia. And by the time it's about day 8 or day 9, the host response starts to kick in. And that's where you probably get to see a lot of these patients getting into the cytokine storm and getting more and more sicker. Not everyone gets into this phase. The general consensus is about 80% of these patients get away with this initial phase of viremia, get some mild symptoms. A few of them need oxygen or hospital admission for that matter. And even a smaller subset would need ICU admission for that cytokine storm that follows. The mechanism, well, if you go into the level of, I mean, like, there are a lot of things happening at the molecular level, which may be potential targets for intervention. The things that has been described is the affinity of the SARS-CoV-2 to the ACE2 receptors, which in turn, leads to a surge in your angiotensin levels in your body, while at the same time, this whole cascade of attachment to the receptor starts kicking off the other coagulation systems and other things to be activated. So a lot of things happening simultaneously, which eventually results in a lot of pro-inflammatory cytokines being released and essentially, causing the damage eventually. Now, in terms of what can be monitored or how this translates to a bedside intervention or bedside interpretation, I would think, there are a few markers which are currently being used apart from the level of individual cytokines like IL-6 or IL-10 that are being measured. We routinely monitor things like CRP and ferritin as well to see how much the host response is like. And what we've found here is most of the sick patients who hit the ICU eventually, when you keep following up these markers continuously, you get to see that, levels of ferritin are quite high, as high as, a few thousands when they are very sick, intubated, and are being paralyzed for severe ARDS. So those would be some of the markers that would be useful. Now, coming to the question on steroids, again, you would think there is definitely on one side evidence-based medicine and on other side experience-based medicine. Now, when you look at evidence-based medicine with regards to steroids in coronavirus infection per se, at least with the SARS pandemic of 2003, there were further studies that showed that you give steroids during the early phase of illness, it prolongs the period of viral shedding. With the MERS-CoV, it was the other way around, where steroids given to critically ill patients, it was shown that steroids was beneficial. So, and a lot of this has been, pulled out of the influenza literature as well, where use of steroids has been equivocal or sometimes even been detrimental. So overall, the recommendation for COVID-19 initially has been that say no to steroids. But as we study or as we understand more about the immunomodulation or the cytokine storm, the role of steroids in COVID-19 is slowly opening up. There is this big study that's been registered on clinicaltrials.gov where China, where Beijing is doing a big study, a randomized control trial with steroids versus no steroids in COVID-19 patients. The results of the trial should be out by the end of this month. So we'll have a better answer in COVID-19. But as far as the mechanisms go, I would think the use of steroids in mild disease probably may not be great. You have to probably time your steroids, if at all you're planning to give, during that phase of the start of host response or the start of cytokine storm. Now, this is going to be very difficult to predict at what point of time you started, and that's where the whole confusion is. I think a lot there is upcoming literature to say that steroids given at that right therapeutic window will be useful. If it is given at a later stage, towards the critical stage of illness, it's probably too late. You may have some detrimental effects as well. So if you were to ask me whether there is any evidence for this, I would say there is no. If you ask me my experience on using steroids, we do not use steroids, but it's more anecdotal at present. As I said, if you are able to capture that sharp window where you can give, it may be effective. And this is purely out of logic and therapeutic reasoning that I would say steroids would be indicated. Otherwise, we will have to be careful till we get evidence on this.
The mechanism of cytokine storm, what are the different biochemical parameters that you might use to one, diagnose cytokine storm, and secondly, how would you advise that we manage that?
Is in the setting of a cytokine storm that we have seen in bacterial sepsis too.
Right.
Use of immunosuppressants or anti-inflammatory therapies have been failures. Okay.
Exactly.
Having said that, in this setting, we may be, as Dr. Ramanathan said, we are seeing some form of a positive result in a subset. Why do you think so? And what would be the difference that you see between an anti-inflammatory therapy or a immunomodulatory therapy in bacterial sepsis vis-a-vis in COVID-19?
Yeah. I hope I can find out exactly and tell you what's happening differently in these patients. I think that literature is going to come out later. As Dr. Ramanathan said, there's literature and then there's bedside experience. We started off with the same premise that steroids are going to be bad in these patients based on SARS-1, MERS, influenza, and all the society guidelines. Even now, they are saying don't use steroids. Now, what we were seeing is when we were hit with the first wave of our COVID patients, we basically had no therapy, and supportive management that was is what we were doing, and we were seeing these patients die. So I read a autopsy report that came out. I think there were 2 or 3 patients in that autopsy report, and what they mentioned is that they saw what is known as acute fibrinizing organizing pneumonia in these patients, AFOP. Now, organizing pneumonia responds to steroids. We know that, and what we started doing in our 3rd week of managing these patients is we started selecting these patients and seeing if you can selectively give it to a certain set of patients. As what Dr. Ramanathan said, timing may be important. So how did we guess a timing? How did we come up with a timing? So when we started seeing these inflammatory markers or oxygen requirement going up, so if somebody was, let's say, on 2 liters of oxygen, and we started seeing that they were going on 3 or 4 liters, maybe a high flow, and when they start going down, they go down very rapidly. Or if we started seeing the D-dimer, ferritin, CRPs going up, we said this would be the adequate time, probably the right time to start steroids. So what we did, we started off with one patient. We gave that patient 1 milligram per kilogram in a divided dose, approximately 40 milligrams BID. And what we saw was a dramatic turnaround. This patient literally turned around in 48 hours. So that was a success story. But as you say, one swallow doesn't make a summer. So we said, okay, we'll try it on a second patient. So far, I think we have had an experience of over 10 to 12 patients. And surprisingly, we have been able to stem the tide of deaths that we were seeing, and stem the tide of number of patients who were going from nasal cannula to high flow to getting intubated. And we have probably about 10 of those 12 patients who got better. Their oxygen requirements went down, their inflammatory markers went down. Having said that, it's not always a rosy picture. We did have a couple of patients who didn't do too well. Again, it could be the timing that we started the steroids at. One of them did develop a super infection and apparently had a bacterial sepsis, eventually died. And the second one just got worse, initially got better, then got worse. And I think there's a super infection that is going on and has just gotten intubated. So timing may be important. The exact mechanism, now steroids are a big gun. Basically, it's like suppressing the entire, inflammatory storm at the go. But as you mentioned, from past experience, steroids have not been very helpful in managing any of the cytokine storms or any of the inflammatory storms that we have seen, either in bacterial sepsis or prior viral sepsis. Now, is there something different over here? I'm not exactly sure. But is there that organizing pneumonia part of it that may be the case why these patients are turning around? Could be. I think time will tell. But at this point in time, we are selecting our patients well. We're thinking of starting early when the markers start going up. And the second thing we do is we try not to use two anti-inflammatory at the same time. The second anti-inflammatory that we are using in our practice is tocilizumab.
Mm-hmm.
We are worried about superinfections, and both being anti-inflammatory and these patients being immunosuppressed, we don't want to do that. So what our protocol says is, if the patient is a candidate for tocilizumab, we give them tocilizumab. If the patient gets better, we stop their general supportive care. The patient after tocilizumab, 24 to 48 hours, is not doing well. We start seeing the markers going up, oxygen requirement going up. Then we give them a trial of steroids. And what we have seen is actually majority of the patients who got toci are ending up getting steroids, and that's when they turn around and get better.
So which is the subset you're using tocilizumab in? And do you think it is that COVID has a strong element of HLH or hemophagocytosis, and that's the reason why that you have the immunomodulator action, which probably is working better in this setting than any of the, H1N1 or any of the other forms?
Yeah, possibly that's a hypothesis. And the subset of patients that we are using toci is again exactly the same. For anti-inflammatory, our protocol is the moment we start seeing oxygen requirements going up or markers going up is when we consider that patient for anti-inflammatory, and then we see which one we have available. Now, toci, if the LFTs are more than 5 times above the reference value, we don't use it because of the liver issues, and then we go to steroids. But if that is the case, we start with toci and then monitor the patient, and still not doing well, then we go on to steroids.
Okay, right. Thank you. Vijay, you would like to take over now again?
I want to just expand a little bit more on this topic. Would you consider it for a patient who has got fairly severe ARDS, not the cytokine storm group? And if so, would you use it as rescue therapy or routine therapy? And what would be the dose?
Yeah, I think we have a little bit of literature in there, the ARDSNet study that was published in 2006, which tells us that these patients probably will not do when they get to that stage. And we are talking about the, almost fibrosis setting in, it's middle to late ARDS. These patients tend not to do well when you give them steroids. And definitely, if it's been more than 14 days after the onset of their lung injury, we have literature to support saying that these patients have pretty bad outcomes. And using something as rescue therapy and then they have a bad outcome, then you have a skewed literature or skewed experience over there. So no, once they go on to full-blown ARDS, we are not initiating steroids at that point in time. So let's say a patient was on high flow, was started on steroids. We continue the therapy if they tend to get intubated, but our duration of therapy is 5 to 7 days, is a slow taper over the next 2 to 3 days. But definitely not when they are intubated and are in the middle to late phase of ARDS. I think that may be a little bit too late in the clinical phase of this patient to start steroids, and we may be doing more harm with superinfections, hyperglycemia, etc. in those patients.
Why not early proliferative phase?
Yes, exactly. So, we can't phase. And if I could go into the lung of this patient, get tissue and say which phase this patient is, I would definitely time my steroids. I think for us right now is when the oxygen requirements going up, they're not intubated, and we are seeing inflammatory markers going up. Now, yes, if you go into the ARDS study that was published, the patients were enrolled at day 7 in that. So we have this day 1 to 7 question mark that still exists. And Dr. Meduri, who's a big proponent of steroids in that early phase, but remember, by the time they get intubated, we are saying the cytokine storm has hit in these patients. They are in their day 10 to day 12 clinical stage. So we are talking later, not earlier in the phase of ARDS. So that's why I'm a little bit cautious not to give it when they get intubated and they're in the middle of it. Rather than try it earlier when the cytokine storm or markers are just rising in these patients.
To add to that, one safe strategy could be, because we don't want to harm patients, is what we instituted, and some other hospitals have done so as well, is that we had a protocol of measuring ferritin and procalcitonin every other day for everyone who was in either critical care or in the acute ward, because we had in total of about 300 patients. You can't do that sort of protocol for everybody, but people who are in acute respiratory ward or in critical care, they had alternate day ferritin, CRP, and procalcitonin. And we had a group who declared themselves as rising ferritin with normal procalcitonin. And in that group, I think most people will feel safe to think of using steroid. And as Dr. Khosla said, we did use 1 milligram per kilo methylprednisolone in a small group of patients. But at the moment, there are 2 trials going on, fairly large as well. A recovery trial, which has recruited about 8,000 patients so far, and that has a steroid arm. And REMAP-CAP, which is for intensive care patients, that also has a steroid arm. So hopefully we'll get some answer in the next couple of months on that. And we have recruited in both. Truly speaking, we don't have the answer, but we devised a way of finding a safe way to offer steroid in a small group of patients with high ferritin and normal PCT.
I'll just add one thing, Dr. Sarkar, over there. So what we have noticed is we have also been measuring procalcitonin and ferritin. Surprisingly, a lot of our COVID patients are coming with high procalcitonin levels. Do they have a superimposed bacterial infection? I'm not really sure. Cultures are not always positive in these patients. So we are collecting data and trying to see what's going on. Majority of our patients, I would say more than 60 to 70, now just looking back after managing this, patients, procalcitonins have been more than 2, some in the range of 10 or 12. So that has been a little bit surprising. So for that reason, I did not use procalcitonin as a marker to decide whether to use or not use an anti-inflammatory in these patients. For some reason, our subset are coming with a high procalcitonin.
Thank you very much. So I would like to welcome her to give her thoughts on coping with COVID, and maybe we can get back to the therapeutic aspects after her discussion.
So anyway, I can just introduce myself that I'm Jennifer Mitty. I am an infectious disease specialist, but spend most of my time working at UpToDate, which is an online medical resource. We are part of Wolters Kluwer, but professionally, I see inpatients and outpatients in Providence, Rhode Island. I'm connected with Brown University. So I've sort of get to wear 2 different hats, which is interesting. But just again, a little background about Wolters Kluwer, Wolters Kluwer is a large company that has a large health division, and we UpToDate and Lexicomp and Emmy are all part of the clinical effectiveness group, and we focus on helping providers. UpToDate is a clinician-based tool to help provide decision support. And for those of you who aren't familiar with it, we have nearly 2 million users over 191 countries. And it's in the US, it's used by about 90% of the teaching hospitals. And we get about 1 million searches a day. And the goal of UpToDate is really to clearly and succinctly answer important clinical questions based on the best evidence. And I think that as listening to your discussions, that's clearly challenging in the time of COVID, because there aren't necessarily clear answers and the data is rapidly emerging. But what we do hope is that by trying to answer questions, that we can impact and improve outcomes by helping synthesize the information and provide some actionable recommendations. So I just want to, again, trying to keeping up with the pace of knowledge of COVID has definitely been a challenge. And just to sort of understand, to give some background, our typical editorial process involves a group of internal physician deputy editors, expert authors, and expert section editors who look at different clinical studies, review, and I think one of the big things we try to do is not just recite what the study showed, but is to really try to show the clinical significance and how to integrate those findings into your clinical practice. Sort of, again, listening to your conversation, you were just talking about waiting for the data to help guide you. So we don't try not to just recite the studies, but also decide how to put it in clinical practice. And in our usual editorial process, updates can take weeks to months, depending on the number of studies. And a new topic can take months to get published to try to work out all the details and the nuance. But in the era of COVID, this has been different. And just to show you briefly, we've had, I'm just pulling up my, we've had over 100 updates and 32 new topics that have been developed since the beginning of, since pretty much the middle of January through where we are today, and this is all in response to this sort of growing amount of literature and experience in trying to help providers learn how to care for these patients. And clearly, people are looking for support, guidance as we try to make decisions in this uncertain time. And we've had over 7 million hits. This includes both up-to-date content, our Lexi drug information content, and our ME patient videos and patient content. So I just thought I'd, again, just to let you know also that not only do providers need information, but we also, the patients, providing patient information has been key. And we've been able to provide some patient education, links to the multiple guidelines that are out there because there's numerous. So trying to almost sort some of the information so it becomes usable for providers out there. So I just thought I'd show a little bit the process of our COVID expansion and try to, again, our goal is to sort of provide, we can't do webinars and have such an exchange of ideas like this all the time, but try to provide readers with some of this exchange of ideas. So just to show you a little bit about sort of the process that happened for us is in January, we did an update into an existing coronavirus topic about this novel outbreak in Wuhan, where they had the first 41 cases described. And by February, so about 3 weeks later, this topic had already been updated 15 times, which, many of our topics get updated once or twice a year. By February 5th, we had so much information that we really needed to create a new topic. So as new information evolved, so did we. And we created a topic. And again, as you can see, it was the old name of the COVID, what is now called COVID, this novel coronavirus. And we, we're proud. We touched on all aspects of what we were learning about this viral infection. And then, we had a very skilled team of contributors. Ken McIntosh is a professor at Harvard Medical School and is an expert in coronaviruses. He's a virologist, as is Dr. Hirsch at the Mass General Hospital, an expert virologist, and our in-house deputy editor who worked from the up-to-date side is also at Mass General and at Harvard Medical School. So we, had this great group and we kept updating our topics, every day pretty much. And between February and March 30th, this topic was updated 38 times. And, again, the contributors were adding updates close to daily. And then as the field expanded, we even needed to leverage other authors and experts from different specialties. So example, nephrologists, when the use of ACE inhibitors was being decided, and OBGYN and pediatric contributors to address management in pregnant women and newborn care. And so as of March 37th, we were up to version 37. And you can see what started out as a small topic has now expanded to multiple complicated issues and nuances and was sort of busting at the seams. So what we realized, and based on reader feedback, is that we really needed to provide our readers with more guidance about what to do. And we really needed, and again, you started listening to your conversations today, we really needed to leverage the experience of authors and editors from multiple specialties who are on the front line to help synthesize the data and provide readers with as much actionable guidance as possible in this uncertain time. So we started to create some management topics. We have a critical care issue topic. We have management in hospitalized patients, and actually now have one on outpatient management in adults. And so just to, we can just sort of jump to the one with the critical care issues. We've tried to provide a lot of actionable evidence, or as much as possible. So, starting off with looking at oxygen requirements, and then trying to decide when to intubate, which, you are all probably more familiar with the uncertainty and debates that comes with. So these topics are continuing to evolve as new experience and new literature is out there. And then, again, we talk about ventilator management and trying to sort of, again, walk people through the different steps and different issues involved in critical care management. We discuss interventions. We have in this topic and in the management topic talks about steroids as well, the use of steroids. And then in some of our topics, we also provide information about the experimental agents that are out there and trying to figure out how do you sort through all that data as well, because that continues to evolve rapidly. One of the other things that we ended up creating, which was new for Up to Date, was a frequently asked questions topic. Because there are certain questions that we found, we received multiple feedback from readers. And so we tried to create a FAQ topic where readers could quickly find their answers. So for example, the ACE inhibitors, we were able to tell people, keep going, don't stop, because that's really the big question. But then for those who are interested in learning more about the data, they could click into the topic and really learn more about the data that inform that decision. And you can see from the topic on the next slide that, we start to expand the data discussion. And it's funny, I took this clip yesterday and the topics are already in edit with at least 3, I think there were 2 new studies published in New England Journal on Tuesday. And so next week, this section that I've circled will be greatly expanded given the evolving literature. And again, trying to provide actionable guidance to clinicians. So again, by the end of April, we have now numerous topics that have been created with, great appreciation on our end for the authors and section editors who are in the field and still taking the time to share their experience and help us try to synthesize the data that's out there, and let us know how to think through these complicated patients. And again, we've sort of now have care about pregnant women, children, ICU management, anesthesia management. We actually have issues related to care of patients with cancer and psychiatric health. We also have multiple now guideline links pages so people can look either looking for general guidelines or specialty guidelines, and then multiple patient information topics, which people can send to their patients. All of our up-to-date content is open access. So this allows, any clinician to be able to use that, or patient for that matter. And then one of the other things I just thought I would share because it's interesting is we've created almost like a heat map. And what we found is that up-to-date hits can predict cases. And if you look at the screen showing about India trends, you can see that in March, in the few weeks preceding the increase in cases, there was an increase in the number of hits about to our COVID topics. And then there was a subsequent increase in cases. So again, if you're interested in looking at this, you can access the map through our general home site, uptodate.com home COVID-19 access, or through the map site in general. So just to summarize that we've really been trying to, in our way, deal with this rapid pace of COVID-19 and trying to provide readers and clinicians all over with information that can help them care for patients and hopefully improve outcomes, So for us, that's meant really sort of accelerating our process, trying, maintaining quality, but all hands on deck with contributors and internal editors to really get the topics updated on a frequent basis, creating new topics when we need new specialists to weigh in, because we really do need, again, people who deal in the specialty and are on the ground to help inform these topics. And then again, really hoping we can try to provide some actionable guidance, while at the same time recognizing the uncertainty, as you guys, had mentioned, do no harm at the same time. So I think this is such an interesting and hard time to figure out how to practice the best quality medicine. And so this is sort of some of the challenges that we've had to face on our end and how we've tried to adapt to this. So thank you. If anyone again is interested, you can go to our site for these COVID topics, and there's reader feedback. So if there's any information you think we should be including or expanding on, we would love to hear, so that we can try to incorporate your experiences as well, and address any uncertainties that you think we could do better.
Thank you so much. I think we can cope with COVID better by going to UpToDate. Is that your take-home message?
Well, hopefully, but again, it's also just, hopefully we can sort of share the information as we get it, so that forums like this that you're having to share ideas, that we can at least try to present to people who don't have access to forums like this, as well as to everybody, I guess. So hopefully we have an impact.
Thank you. Do you have time to take a couple of ID related questions?
Sure, I would be, if I can answer them, I will do my best.
Now, somebody who has had a COVID infection is completely recovered, gone home. In 2 to 3 weeks' time, if he gets exposed to another positive patient, he or she, can they develop another infection?
So it's not clear. I think we haven't had, I think this question of reinfection I think we don't understand enough about the antibody response to know whether people can be reinfected. And in such a short period of time, it's unclear whether it's sort of a relapse versus reinfection, because I feel like we haven't had enough duration from the original, just literally haven't had enough time since COVID started to know what the natural history is. So I think people aren't clear whether there's really reinfection at that point or relapse. And then the other question is viral shedding. I think we don't know the significance of viral shedding as you go out. Some people will be asymptomatic but still shedding virus for weeks, and it's unclear whether that's infectious. And many experts are feeling that weeks out, it may not be infectious virus anymore. There was a study by Wuffel from Germany that did not find the virus to be culturable after a certain period of time. It was a small study, so again, I'm not sure anyone's drawing definitive conclusions, but it looks like people can shed without having culturable virus and therefore wouldn't be infectious. So unfortunately, it's a long way of saying I don't know, but these are some of the issues that we're sort of thinking through.
Thank you. Those thoughts certainly help. Thank you so much for your time and for your insights on some of the questions we had.
Great. Thank you so much. Thanks for giving me the opportunity to listen to you as well. I've learned a lot as well just listening. So thank you.
Thank you. For the next session on pruning, which is, I think, something that is of great interest here.
Right. Dr. Ramanathan probably touched upon it as we were speaking, awake pruning. And I would like to continue with that and talk, with Rahul Khosla. If you could tell us in which setting are you pruning these patients? Are you doing awake pruning or only after intubation? How long do you prune? How many times do you prune? Because it seems to be a pretty prolonged illness, and before probably going on to ECMO, and we'll come to ECMO a little later. Start off with Rahul, but any of the faculty could.
Sure. So I think Dr. Ramanathan mentioned about awake pruning. So we are doing awake pruning. We are pruning patients who are on the ventilator. We can go back a little bit to the literature. So we do have definite evidence over here in literature regarding pruning. So we have, we had case series and small studies till about 2015-16 when the French study came out on pruning the patients on mechanical ventilation, which actually not only showed a benefit in oxygenation, but also decreased mortality. But somehow, surprisingly, pruning never became a very big thing in most of the ICU, especially in America. I think there's a mindset, there's some kind of inertia. This COVID pandemic, I think, is definitely going to change that. Now, though that study was on patients who were on mechanical ventilation, so we are talking about positive pressure ventilation. Now, awake pruning, if they are doing it on nasal cannula and you're doing it in high flow, we are talking about negative pressure ventilation. So it's a different, on negative pressure, normal breathing. So the physiology may be different, but I think at the end of the day, you're trying to do the same thing. So awake proning, there was one trial that was published, I think, in 2015 in Intensive Care Medicine or Journal of Critical Care, I forget which one of the two. But they only had 15 patients, and half the patients were on helmet CPAP, some of them were on nasal cannulas or high flow, and these patients did well. 15 is too little a number to talk about mortality. Now, when this COVID pandemic hit, I think wherever it hit first, China, then in US, in New York, there are some studies that came out of there. So I think there's an ER study that came out of New York, where they awake prone 50 patients in the ER because they were so overwhelmed. They just started awake proning these patients in the ER. And what they found is that 64% of these patients, intubation was prevented. So we had some guidance from background literature, and we started doing the same. So who are we proning? Definitely a patient, when the patient gets intubated, that patient is proned. How long are we proning? We are proning as per the ProSeva study. We are doing it for 16 hours. So our protocol is 4 p.m. the patient is proned, and 8 a.m. we wake up the patient, I'm sorry, supine the patient. 16-hour duration. Awake pruning. So we didn't know how exactly to start and who to start on. Because if you look at all the studies, the inclusion criteria in the ProSeva study, these are patients with moderate to severe ARDS, PO2 F5 ratio of less than 150. So are these subset of patients behaving that way? Definitely all the patients who are intubated, they have a PO2 F5 ratio, which is really, really low. Most of them are less than 100. They meet the criteria. Not all awake prones meet that criteria, and we don't have an ABG on all these awake prones. But still, what we wanted to do is, number one, we wanted to prevent intubation. We knew that patients who are getting intubated are not doing well. So we basically started proning everybody who's requiring at least 4 to 6 liters of oxygen. So if they have that requirement or high flow nasal oxygen, and it's easier to talk to a patient who's awake and alert and explain what you're trying to do. And surprisingly, most of our patients have been very, very cooperative. So we will awake prone them, and what we would tell them is try to be on your chest as long as you can tolerate. So there's no protocol because they're awake, and you can't force people who are awake to, follow a certain protocol. And most of them, surprisingly, are doing it. I mean, they are literally the entire night, they'll be sleeping on their chest, and then they will wake up, eat something, and they'll go back on the chest. So awake proning, we don't have a set protocol. We are encouraging patients to do as much as they can. For intubated patients, it's a 16-hour protocol that we are following, unless they're in shock or something. Luckily, we have not had any of those patients. So this is what we are doing, and what we are finding is definitely an improvement in their oxygenation. Now, if you read the latest editorial that was published by Dr. Gadinoni, now he's talking about two subsets of patients. He's talking about an L type and an H type, and he says H stands for high, patients who have high elastance, high recruitability, high right to left shunts, saying these are the traditional patients who will benefit from, proning and managing like a traditional ARDS patient with lung protective mechanical ventilation. And then he talks about the L type, where you have the low elastance and the low shunt and the low recruitability. And he's saying these patients have, although they have severe hypoxemia, the physiology he's hypothesizes that is the hypoxic vasoconstriction, which may be lost. And he's saying that these patients actually may not benefit from proning, and they may require higher tidal volumes. I actually may want to disagree slightly, because I think it's not a binary over here. I think it's a spectrum. And we are seeing that even those patients who are on 2 to 4 liters, who may fit his L type that he's describing, are benefiting from proning. You prone them and you immediately see the saturations go up. Now, how long, duration-wise? I think our goal for patients who are not intubated is to prevent intubation. So as long as the patient is cooperative, as long as the patient doesn't look like he's moving towards, a permanent respiratory failure requiring intubation, we are encouraging proning on a daily basis. And then on intubated patients, we do it daily. I think there was a question regarding ECMO. We have ECMO, veno-venous ECMO capability, but we haven't used it as yet. And I think why, the question is why. As I said, proning for some reason has never been utilized in a major fashion prior to the COVID pandemic. And our practice was the same. But I think this COVID pandemic has at least brought one positive. I think we'll be proning more patients going forward. ECMO is an invasive technique. ECMO is not very readily available. Secondly, we do not really know in the literature. You know, there are some couple of, like we had the study in 2011, and then 2000 EOLA study that was published in 2018, which actually was stopped earlier because it did not show any benefit of ECMO regarding mortality, or we had oxygenation benefit. So we are not moving towards ECMO as long as we are seeing that the PO2 or 5:2 ratio is getting better. So as long as it's more than 70 and getting better every day, we have not thought about ECMO, but we may end up getting there on some of our patients. But awake proning is definitely helping. Proning these patients on ventilators is definitely helping. Physiology might be different in awake and in positive pressure mechanical ventilation, but at the end of the day, I think it's a transpulmonary pressure difference, which is opening up the dorsal collapsed alveoli, both in awake and in positive pressure. So our experience has been positive, and we are going to continue doing that. And I would like to hear from others as to what they are seeing in their practice.
Yeah, thank you, Rahul. Dr. Ramanathan, your experience about ECMO use in the setting of COVID, how is it, what are the subset of patients that if you choose, and is the subset of patients you choose to do it in, and what are your findings if you have done it in ECMO in COVID patients?
So patients who go on to that extreme of respiratory failure needing ECMO would have to satisfy a few criteria before they get ECMO. So essentially, not everyone gets ECMO. And one thing which is a part of that criteria is proning the patient. And as Rahul alluded to, I totally agree with him. We don't accept patients for ECMO unless and until our peripheral center or our own people have prone patients and they've found that proning to be ineffective. Now, having said that, we were anticipating a lot of patients needing ECMO at the start of the pandemic in Singapore. So Singapore got prepared in terms of resources for that as well. But surprisingly, what we find is the more the patients are getting prone, the lesser my referrals are. So even patients who are getting prone for more than 4 times or 4 cycles, that's what the ProZiva trial did initially. And that's, if they consider that as a standard of care, we even encourage patients to be prone a bit more. There are anecdotal reports of patients getting better after 13 or 14 cycles of proning. So proning is definitely a big, is a stopgap before somebody is considered for ECMO anywhere in the world. It also has come out with guidelines for ECMO, and that includes the set of management of ARDS, which includes proning as well before you consider someone for ECMO. Again, few contraindications like age-related or surge-related contraindications may come over these patients. Globally, there are more than 1,500 patients currently who have had ECMO, about 1,000 plus in Europe, 500 plus as per the registry in North America, but I'm pretty sure it's more than 1,000 there as well, listening to my colleagues there. So a big chunk of patients, or at least a small percentage of patients, are getting extracorporeal lung support, predominantly venous ECMO. And they at least as of now, the outcomes, whatever has been gauged so far, survival rates are anywhere between 50 to 60% for these patients. We've had 4 patients in Singapore who have gone on ECMO. As I said, the number of referrals are definitely happening, but we didn't filter them with our criteria for ECMO. We are very strict about who gets ECMO in this context of COVID-19, given it's a resource-intensive affair. Of the 4 patients, 2 have been explanted, so 2 died. So essentially, what we find is while we go on, or while we initiate ECMO, these patients are in the peak of their cytokine storm. They're on high inotropes, they're coagulopathic, so they do have a lot of bleeding complications. But most of them have a course of about 10 to 14 days. The longest ECMO run I've heard from my colleagues is from South Korea, where a patient was on ECMO for about 37 days and survived. So yes, ECMO has a role, but it's still used as the last ditch effort if your resources permit. ECMO would not be a frontline therapy if there is a big surge. It should be done carefully. It's not that we all want to do ECMO for the sake of numbers. If we were to recruit or initiate ECMO in patients, they should be they should have standard set criteria for a good ECMO run. Hope that answers your question.
Please tell us whether you would recommend it for routine use or as rescue therapy or only in the setting of research. We'll start with hydroxychloroquine with or without azithromycin.
Using it, but not using it anymore.
So hydroxychloroquine only in the context of research, we are using it at the moment in recovery trial.
We would also use it only in the context of research.
Okay. Any of the Indian faculty would like to comment whether they're using it routinely for your patients? The second question. Yes, sir.
I think we are using as of now in the minimal care symptoms of people are using it routine in India, and let me put it very bluntly, every practical, all the majority of the physicians itself are taking as a chemoprophylaxis. Whether it works or not, we don't know. We are collecting the data. I think that is a hard truth, whatever we may say.
Thank you, sir. The second therapeutic modality is high-dose vitamin C.
Only in the context of research in Singapore.
Context of research.
We are hearing some anecdotes that in some American centers have used it quite widely, and that has helped. But again, we have not used very high dose vitamin C.
It doesn't harm, no. Unnecessary vitamins just make expensive urine. So would you recommend it for our patients?
I think IV vitamin C is not easily available, at least in US. When Dr. Merrick started using it in his observational study that was published for bacterial sepsis, a lot of people started using it, but now we have a randomized study showing no benefit. So the use has gone down, and IV vitamin C is a little bit difficult to get in the US now.
And the dose recommended is quite high as well.
That's right. Remdesivir. With the new evidence coming up, are you sold out to make the Gilead shares go up?
I think I would recommend it to use it in clinical practice. Getting it is a little bit difficult. We are enrolled in the trial. So with the new evidence coming out, I would definitely be inclined towards using it.
Still
You're
being
using
used
it in the research setting.
Yeah, here also we're using it only in the research setting here. We're not using outside the research setting off label or anything like that. So I'd use it in the research setting as of now, but there is promising evidence coming out. We'll have to wait and see.
So we have used in individual patients on a compassionate ground, and I think we should wait for more data coming out. Animal data is more promising for remdesivir than hydroxychloroquine, for example, which there is none.
Let's move on to other antivirals or other antimicrobial agents. Anything that you would suggest out of the research context for routine or rescue therapy?
Only in the evidence of any supra-infection, I would use it. Otherwise, not on a routine basis, and not even on a research setting. I'm not sure why would I use the antimicrobial in this setting. I mean, I know azithromycin was used, but that was used as to prevent a supra-infection in these patients.
In the recovery trial, we are using azithromycin as an arm and lopinavir, ritonavir as another arm, and we'll see what the result shows. But then there is a report of superinfection with or co-infection with influenza, and whether someone wants to use oseltamivir, that's obviously a very pertinent question.
Tocilizumab?
We are using it clinically as an anti-inflammatory in clinical practice, and definitely in a research trial too.
So tocilizumab is an arm in both the trials that we are using, REMAP-CAP and recovery, and we'll see what happens.
We're currently using it only in the context of the research trial, nothing outside it. There is a talk of giving tocilizumab early in the course of disease, the mild form of disease, but nothing has finalized yet.
Therapeutic anticoagulation, based on all the autopsy studies that are coming out.
We are definitely using DVT prophylaxis in all, and we have a protocol based on D-dimer.
Okay, I'll start off. I think it's a very difficult topic or a very difficult thing to prescribe straight away, because you get to see, if you look at the spectrum of disease, you get to see thrombosis at one end and severe bleeding at the other. You don't know where they are. The one thing we can see that is the more severe the disease, the more severe the bleeding complications. But of course, you get to see some stroke and as a part of this thrombosis. So where to start off, we don't know. It's an interesting guide was published last week in European Heart Journal Cardiovascular Therapeutics, where they have based a lot of this anticoagulation on protocols on D-dimers and other things. But looking at the protocol as well as what we practice, we do give all patients prophylactic heparin for sure. Those who come to the ICU with severe cytokine storm, we do start them on heparin infusion and try to figure out if, especially when their D-dimer is raised and other things, and try to see if we can get an early imaging to see if there is any evidence for thrombosis anywhere. And as of now, unless and until their coagulation parameters are totally deranged, we continue with heparin for now.
Dr. Khosla?
Yeah, so definitely DVT prophylaxis in every patient, and what we are using is, although every society out there, hematological society, is advising against, but we are using, because we have seen so much of clotting, it is just shocking. I mean, we had a patient, his entire arterial supply in his brain had clotted off and he herniated in front of us. We have had patients, the second thing I'm noticing is that any place you put a line, you go and do an ultrasound after that, you will see a clot. So there is extensive clotting. So we are using D-dimer as a marker. So our cutoff is 4. If the D-dimer is more than 4, we are giving full therapeutic anticoagulation. Some of the area hospitals are using a different protocol. They have a cutoff of 5, and then between 2.5 to 5, they use an intermediate dose, which is they've invented. They're giving twice the DVT prophylaxis dose. So we are using, because we are seeing so much of clotting, we are therapeutically anticoagulating based on D-dimer.
So to add to that, 2 points, there are a few studies which have shown that up to 70% of these patients can have a VTE, even if not clinically diagnosed before, if you just routinely scan everyone. And then the autopsy studies, as we're talking about, they have shown that there might be a complement-induced thrombosis, microvascular thrombosis in a lot of these patients. So generally speaking, what we are doing is we are doing a D-dimer-induced, D-dimer-driven, low, intermediate, and high dose anticoagulation. For our cutoff is around 200 in D-dimer. And for below 1,000, it's normal prophylactic dose. 1,000 to 3,000, it's an intermediate dose, which is essentially a 5,000 BD of fragment dalteparin, and above 3,000, it's therapeutic anticoagulation. And out of 80 patients that we had in our critical care so far, we have seen 2 patients bleeding. Both one was upper GI and the other one lower GI, non-fatal, mild. So far on that strategy.
I'll just add one thing to it. I just saw a study this morning, actually, which is going to, it's a pre-published article that has come out. It's going to come out in JACC. Anticoagulation in patients with COVID, they noticed that there was a mortality benefit, especially in patients who were on mechanical ventilation. Now, in the protocol, in the study, they don't have a supplement as of yet. So I don't know how they decided to anticoagulate whom or not, but they used therapeutic anticoagulation. And in mechanically ventilated patients, they saw a significant benefit. The more pertinent question that is going to come up is, once these patients get better, do you discharge them on therapeutic anticoagulation, and for how long? And I think that's what we are debating now, because we are in that phase where we are discharging patients home.
So this is a very realistic problem for all the discharged patients now. So the British Thoracic Society guideline right now is for the patients who have been on therapeutic anticoagulation, we keep them on 4 weeks of anticoagulation. Whether that's true or right or not, no one really knows. And we are at the moment thinking of scanning patients on the higher end of D-dimer whilst they were in hospital at follow-up to decide what we do with them later on.
Vijay, you have to unmute yourself.
There's a lot of excitement about plasma therapy in India. What is your thought on either plasma exchange, plasmapheresis, or convalescent plasma? Dr. Khosla.
I would say it's all in the research setting. We are enrolled in a research protocol. We have multiple patients enrolled, but we are waiting for the plasma to drop from the sky because it's so difficult to get it. All that I've read in the literature is coming from China, some from Italy, is that they've shown, definitely shown clinical benefit. But again, I would say it's in the research setting that we would use, and I'm hoping our first patient to get one.
Tissue level, it might be actually harmful. So really speaking, we should really use them under a trial setting. And again, both of our trials that we are recruiting currently are being added on with a plasma arm. So we'll have to see what happens. Outside that, no one is using plasma therapy in the UK.
The concept of passive transfer of immunity, convalescent plasma, is very interesting. But my take on that is essentially, unless and until you're able to measure whether the patients have neutralizing antibodies, the titer of it, there's no point giving convalescent plasma just like that. So till we develop that facility, I think blindly giving convalescent plasma may not be logical or evidence-based that way. But it's a promising concept. We'll have to wait and see how much of plasma, with convalescent plasma, we are able to get. And in the right patient, it probably would be beneficial. In others, it can be detrimental.
How about plasma pheresis or plasma exchange with albumin?
Both of them, I would think. I mean, we don't have any trials ongoing which involves plasma therapy or plasma pheresis, and so I wouldn't be able to comment much on that.
Any of the Indian faculty who are using plasma therapy or have experience? Dr. Arindam, Dr. Anup, Dr. Dhruva, anyone?
Peter, in fact, if you really ask me, these are early days actually, except for Mumbai and other places where you are seeing a large number of people in intensive care. I think even Delhi hospitals are now getting gradually filled up with them. A couple of people did claim in Maulana Azad Medical College. And I did happen to speak to Dr. Tulika Chandra, who is heading the Department of Transfusion Medicine at KGMC. They did it 2-1. Our challenge in India basically is only recently we have started getting the rapid diagnostic test. And I will just share it to you that yesterday, we have nearly 90, we have 86 confirmed cases right now with us at Rohtak. But obviously none of them has been seriously ill except 2, which we are suspecting are in the intensive care right now. Out of these 86, when we checked antibodies yesterday, the duo combo from the South Korea, only 13 have come out positive. And the interesting aspect is, obviously, they are still early days. We are also learning. What we found out was that out of these 13, it's an IgG which is coming positive, not the IgM in that combo. So the question which is coming up, people have been talking, and if you really ask me, the press, the bureaucracy, or the other thing, the thing that probably somebody has got with the Delhi Chief Minister talking everybody like about the plasma therapy, that probably it's a panacea. I think we need to be very, very careful. And the timing is important. You will agree with me. And I think still it's early days for it. If somebody says they've done, a couple of have been done in Delhi, in Max Hospital, I don't think the Sumit has done any of them. Neither has been done in Vedanta. We have got enrolled ourselves with Indian Council of Medical Research, and we have applied for other things. We have made a full protocol now. But till now, we have not done it. And whosoever has come up, I think people have been blowing over the top that they have been benefited. Because we still do not know what is the antibody titers. And what Tulika told me from KGMC was, fortunately for them, the rapid test was positive. So they took it up. Now they varied from 14 to 28 days. No, variation, it is there. Obviously, I will prefer as later as possible rather than early. But we are just looking at the paradoxical responses which we are getting to the rapid test. Out of 56, I was expecting more of an IgM. What we were getting is a 13 IgG positive. And illness is less than 2 weeks.
There are a couple of points that Rahul probably wanted to talk about the protection of the healthcare workers in the ICU. So maybe Peter, if you feel that there's another 2 minutes, otherwise Rahul, you can send us some write-up about it.
Well, because we know so little about the disease, what we can do is we can do the very basic intensive care practices well. And if we have some procedures in place to keep everyone safe, they will be confident in going to the front line and do everything that is needed. For example, examining, doing all the procedures as a normal is very important. So lots of hospitals have come up with an intubation team, for example. And the intubation team is just there with a very protocolized service. And if someone needs intubation, that team goes with a checklist. They are fully PPE'd. They go, keeping the number of personnel to minimum, and they follow certain very salient points. For example, whilst you intubate, we keep if someone is on CPAP, that mask is kept on till the very last minute without taking it off, so that the aerosol doesn't spread. And then, whilst they have a neuromuscular blockade, wait enough that they are fully paralyzed, and then intubate. There is no back ventilation involved during the intubation. And when the tube is in, there is no back ventilation again, but directly attached to the ventilators to keep a closed circuit. And to make sure that when all of this is done, when people are coming out of the area while doffing, there is someone watching people doffing well, because the problem is not with donning. Doffing can be quite risky and can be done wrongly. So someone watching the people doffing properly is quite important. The whole point is, if we can make some processes well and running at every time in the same manner, then the staff get confident that things are working well and we are being supported. For example, when we proned, we made sure that we proned 5 or 6 patients at the same time. And then when we unproned them, we unproned all of them at the same time. So a proning team was dedicated to just proning. And for that, we borrowed people from other specialties as well. So we felt that some COVID-specific safety procedure, which runs every day in the same manner across the board, helped gaining confidence among staff, and no one felt anxious or worried in going to the front line and working regularly without any anxiety. And I think because this is going to go on for a while, that process needs to be instituted very well across the globe, really. And people who have done that well, they reap the benefit.
In that, and I would say you can also start off by doing simulation CPRs, simulation prone and simulation intubation, which we do weekly in our hospital with residents. And we also have a set group of people who are intubating. I have designed the intubation sheet. It's a plastic sheet which covers the patient, prevents aerosolization during intubation. You might have seen intubation boxes over the internet. So you may have to come up with your own local hospital protocols and processes and simulate them so that the time of crisis you're ready and prepared.
You see, that's what is, I agree with you. And what has happened ultimately that Rohtak now it has been a nightmare actually. Infection control is easy to talk about it. It's great difficulty. And especially in a warm climate now with the PPs, it is becoming sometimes far more challenging, and the quality of PPs becomes an issue. But what I'm realizing is, as you very rightly said, Rahul, in particular, doffing is what we have started coming. We have started putting in our digital camera there. And we are now monitoring through that CCTV and trying to do it, because what we realize, when you confront everybody, nobody agrees that they've done something wrong. But the moment you talk about it, they will tell you 1 to 10 steps. But when you see it, you will realize they are doing something else. So what we have started calling them, instead of surveillance cameras, as the digital buddy. So we are trying to put a digital buddy so that it helps see that there is a two-way communication. I think that is very, very important, and probably technology is going to play a lot of role now. Because you can't put people everywhere. And that has become trust me, They made me paranoid as an administrator here, because you have to look at Group C, Group D, doctors, nurses, and residents. And every time a new team comes, a new nightmare starts. So I think it's extremely important, very easy to talk about infection control. And I'm talking from a public sector medical school. You can very well imagine. They're smart ones, but at the same time, and the biomedical waste disposal is again a big challenge. Sumit will realize as an administrator, JV will also realize as an administrator. But trust me, paranoia is so much, panic is so much, they will just run away. We had seeing it in daily labor rooms, OTs. People just run away, leaving everything. I don't know whether you face that thing in UK or US, but this is what we have faced it here. And it is, in fact, somebody was asking me that you started looking tired. I said, it's not the work, it's these pressures which make you feel look like that.
Thank you, sir. I think we have to conclude, and I'll say towards already Dr. Chaudhary has said everything, but once again, very special thanks to Dr. J.V. Peter and Dr. Sumit Ray for conducting this session so beautifully. Also, thanks to Wolters Kluwer, our friends from there, and the team of Dr. Arindam Kar for coordinating and organizing this entire team. Very special thanks to Arindam. So thank you very much, everybody. And I think we will probably once again connect after 2-3 weeks after we discuss with all of you. Thank you so much.